Okay, thank you all for joining us. We still have quite a few people coming in, but in the interest of staying on time, want to go ahead and get started. Good afternoon and welcome to today's webinar. It's hosted by the Georgia chapter of HFMA. I'm Laurie Heavey with Clear Balance, and I'm a Georgia HFMA Education Committee volunteer. All of us, we're all navigating uncharted territory, and as many of our leaders have said, we're in this together. But you guys, your teams, and your clinical colleagues really are on the front lines of this coronavirus pandemic. So thank you for all you're doing. A couple of weeks ago, the leaders of the Georgia chapter of HFMA got together to talk about how we can continue providing value, how we can continue sharing best practices that will help all of us now and in the days to come. And not only did we find terrific response by members offering to share their expertise, but equally from all of you in terms of attendance. We began promoting this new Wednesday webinar series less than a week ago, and the registration numbers are just tremendous. I think it was close to 300 about an hour ago. So it really goes to show you that today's topic, and Elizabeth really will be hitting home with all of you. And I think also, if we have to be honest, we're all probably craving a bit of different human interaction. Spouses, kids, and pets can only go so far, right? So anyway, kidding aside, I'm excited to present today's webinar entitled Hospital Revenue Cycle Concerns Related to COVID-19. Before we get started, just a couple of quick housekeeping items. All of the phone lines are on mute to avoid interruption. We will have a copy of Elizabeth's presentation and a recording of today's session. Those will be loaded to the Georgia HFMA website under the tab entitled In Case You Missed It. And everyone on today's webinar is eligible to receive continuing education credits for participating. Be on the lookout for this in your mail. At the conclusion of today's presentation, we'll have a Q&A session. Please go ahead and submit your questions in the chat box or the Q&A box. I'll be monitoring those and work those through with Elizabeth at the end of the session. So without further ado, for today's session, it's my pleasure to welcome Elizabeth Richards. She's a private practice attorney who specializes in third-party healthcare reimbursement. Elizabeth's expertise includes third-party liability, workers' compensation, insurance appeals, Medicaid, Medicare, and all complex reimbursement matters. Elizabeth is an active member of the Georgia Bar, the Georgia Academy of Healthcare Attorneys, and the Georgia chapter of HFMA. She frequently presents to groups all over the country on third-party reimbursement and revenue cycle compliance issues. So Elizabeth, we're ready to begin. I'll turn it over to you.
All right, thanks, Lori. Good afternoon, everybody. I hope everyone is withstanding this quarantine well. It's definitely a different experience for everyone, myself included, being stuck at home, attempting to work with 2 small children. So there's already a betting pool about whether we make it through this hour without introduction to the Richards children. So hopefully they will stay sequestered outside where they're supposed to be. But we wanted to come together today. Obviously, COVID-19 is on the front of everyone's mind. And for the purpose of the people that are on this phone call, COVID-19 and its relation to the revenue cycle, there's a lot of discussion right now, obviously, regarding the clinical areas of the hospital. But the people on this phone are probably specifically worried about, okay, well, how are we going to get paid for all of these things? And how are all of these changes going to affect the way that we're reimbursed on the back end? So that's what we're going to discuss this afternoon. So a couple of just broad topics that I split this presentation into, starting out with the changing CMS regulations. The CMS regulations are and changes that they're making in relation to the declaration of emergency are basically coming at us almost daily. So some of those have, a lot of those mostly affect the clinical side of the house, but some of them do, in fact, have a effect on the revenue cycle. And so we're going to talk about those. Then just generally billing, right? Billing is the heartbeat of the hospital. We've got to keep the billing going out, and there's some particular concerns as it relates to COVID, and then also just our general billing practices and how they are affected by what's going on with this virus. Then FMLA staffing concerns, new rules regarding FMLA and sick pay went into effect actually tomorrow, will go into effect tomorrow. And then the CARE Act, which is the stimulus bill that was signed last week that has some provisions that relate to the revenue cycle. I built this presentation based on obviously the changing regulations as they come out daily that I'm monitoring, but also related to different feedback and questions I'm getting from clients around particular issues and things that are on their mind as it relates to the revenue cycle. Some of these topics we could discuss for an hour themselves. So the purpose of the presentation and kind of objective is to give you a very broad understanding of all the potential things that could be on your radar depending on the size facility that you are, if you're a vendor helping with a certain part of the process, or if you work in a certain part of the process. Some of these things may not affect you, and some of them do. So again, the general idea was just to give as broad of an overview as possible. There's a lot of material in this presentation, and as Lori said, we're going to upload it. I also tried to make it a resource. There's links to a lot of different CMS sites and things that may be helpful as you continue to navigate this situation. So the first thing we're going to talk about is just the changing CMS regulations. On March 13th, as you know, President Trump issued a national emergency proclamation. And what that national emergency proclamation does from a legal perspective is it enacts authority for the different divisions of the government to waive or modify certain provisions of current law. So under Section 1135 of the Social Security Act, which is the section that we're concerned about as it relates to most of the things in the hospital and healthcare providers section, so a significant amount of waivers. The link to the PDF at the bottom of this website goes over all of the waivers that are currently included in that 1135 waiver. It's a great resource. I'll give CMS a little bit of credit. They have been really on top of getting information out. They're uploading PDFs and Q&As and such almost daily to their website. So I highly recommend that you add, a perusal of the CMS website to your daily practice right now, because there has been a lot of great information. So these waivers took effect on March 15th, but they were retroactive to March 1st. And then we'll talk about in a minute in more detail, but states can also request waivers of their applications to statutes and regulations under these waivers. So I just highlighted a few on these next slides that affect the revenue cycle directly. One of the things, depending on how much of the revenue cycle that you control, if you do anything in the pre-service emergency room department, there were significant changes made to EMTALA. This PDF available on the CMS website is a phenomenal resource as far as going through those changes. I didn't want to spend a lot of time on that today because EMTALA is a little bit outside of the scope of the revenue cycle. But basically the EMTALA changes allow for screening off-site outside of the emergency rooms and make significant changes to the transfer rules and guidelines as it relates to the COVID emergency. Another waiver that affects the revenue cycle is they're allowing for flexibility around your verbal, pre-printed, and standard orders. So they're allowing for hospitals to move to verbal orders or standard orders in certain cases instead of having to go through the regular order process. There's a waiver of the time frame with which medical records have to be provided now, and a time frame for which medical records have to be completed. And then there's waivers around required discharge planning. So a lot of the required discharge planning that you would have to do usually to discharge a patient has been waived. One of the things that I always counsel my clients to do in a situation like this, or any situation where we have new rules or new regulations or new waivers, is to pay attention to the meaning behind the law or the intent. So the intent behind all of these waivers is to concentrate on patient care and, to kind of remove some of the red tape that's necessary in caring for these patients in these situations. And then again, clearing and creating bed space. So the reason that's important is when we think about that as it relates to the revenue cycle, these waivers aren't necessarily being put into place in order to help the revenue cycle and the billing part out. They're really concentrated on, the patient care provision and what's happening in our actual emergency rooms and on the patient floors right now. And I just think that that's an important thing to keep in mind before revenue cycle professionals start relying too heavily on these waivers, because our kind of fight in this battle is probably 3 to 6 months down the road. And when we're going back and we're trying to rely on some of these waivers for decisions that we have made in this state, it's going to be harder to push CMS and some of these regulating bodies to having sympathy for the revenue cycle portion of this, because the actual intent of the law wasn't necessarily to help the revenue cycle out, if that makes sense. Something else they're doing is, these are the additional waivers that are affected by the revenue cycle. There's waivers related to the medical staff as far as allowing different staff privileges that weren't allowed before. A big thing for the people on this phone is they've waived the 3-day hospitalization requirement for SNF placement. So if you are trying to get patients out of beds, you no longer have to meet that 3-day requirement. If there are any critical access hospitals listening, critical access hospitals are no longer limited to their 25 beds and their 96-hour stays. So they're open basically to run as a regular hospital for the length of this emergency. And then there's private provider enrollment waivers. If you were in the middle of enrolling providers, if you need to enroll providers, if you have providers that are getting ready to expire, there are quite a few waivers to let those providers remain active in the Medicare system right now while this emergency is pending. So if that's a situation that you find yourself in, then you'll want to look those up. I wanted to highlight the waiver as it relates to Medicare appeals, because I keep getting significant questions regarding this. Unfortunately, the language that's on this slide is basically the language out of the waiver. It doesn't give us a lot of direction. It's all very, very broad. Basically, the CMS HHS secretary came in and gave Medicare processing and therefore the Medicare Advantage plans the right to be a little bit easier on the Medicare appeals. So they have a right to extend the ability to file an appeal. They have the right to waive the timeliness for request of additional information. They have the ability to utilize flexibility for good cause, meaning that they have the right for a hospital to make a good cause statement as to why they couldn't get their Medicare appeals done timely or in a correct manner. They have the right to process an appeal with incomplete or missing appointment representation. And this is also applicable to Medicare Advantage plans. I caution that just because they have the right, there isn't solid language here that forces them to do any of this. So it's my recommendation that hospitals continue to attempt to file their appeals as they normally would, and that they only use this as kind of a safeguard if they get behind. I don't think now is a time to just say, oh, well, this is a waiver, so we're not going to follow up on our Medicare appeals, or we're not going to send documentations, or we're not going to send AORs, and we're going to be able to fall back on this waiver. I think this is more likely something you would use down the road if, 3 to 6 months from now we've had an issue and we uncover it, as opposed to something that we want to use as a matter of practice at this time. And unfortunately, this is all the information that we have regarding specifically how this is going to work. There aren't details available right now.
Hey, Elizabeth, sorry to interrupt you. There are a few people who are having some difficulty hearing you. So I know you've called in on your phone, but I don't know if you're using a headset or speakers or something, but if you could maybe possibly adjust, and let's do a quick volume check, please.
Okay. Is that better?
It's good for me, so but thank you. Sorry for the interruption. I'll just keep monitoring for everyone.
Nope, that's how webinars work. Okay, so changing CMS regulations specifically to Georgia Medicaid. So as I mentioned at the beginning, the hospitals have the ability, or the states have the ability, to request waivers as it relates to their state programs. Quite a few states went ahead and did this pretty quick after that March 15 law, but Georgia, for whatever reason, waited until Friday to submit theirs. So I just checked prior to coming on this call, and it doesn't look like Georgia has gotten a response. I'm not sure what that response time period is, but Georgia did request those waivers on Friday. If you go to their website, you can read them. The Georgia Medicaid, the DCH website has them on there. I went through the waivers and these granted, but some of the things that they requested as it relates to that would be interesting to the revenue cycle is permission to target services on a geographic basis, varying the amount, duration, and scope of service based on population needs. Big to the revenue cycle population or interest is the expanding of presumptive eligibility to include everyone over 65 and the disabled population. The ability to make interim retainer payments for hospitals, SNFs, and other providers that are deemed essential. So kind of front loading those payments and supplemental payments, which we'll talk about that at the end of the presentation. And then waiving pre-authorization and easing private provider enrollment. So Georgia didn't select everything on the list, but they selected a good variety of the options of things that they could request. At the bottom of this slide, you'll see the Kaiser Family Foundation has a fantastic resource. That's what this link is, which is showing all of the states and all of their action on the Medicaid waivers. So if you're listening to this and you're not from Georgia and you're looking for information on another state, that Kaiser Family Foundation website is a great resource where they're keeping kind of up-to-date information regarding the states and what they've done. All right, one of the other big changes right now as it relates to the provision of care is telehealth. Telehealth was actually authorized back on March 6th in what was called the Coronavirus Preparedness and Response Supplemental Appropriations Act. It was expanded a little bit in the emergency declaration and then a little bit more in some other things, but the kind of basis of it goes all the way back to March 6th. Basically, they enacted a law which lifted all the situations where Medicare patients can receive telehealth. Previously, a Medicare patient was only eligible for telehealth if they were, if they lived in a rural area where they didn't have access to the care they needed. And then they also had, to go through a process where they got a originating site and an established relationship in order to be eligible to receive those telehealth services. All of that is gone now. So any Medicare patient, despite where they live or what the situation is now eligible for telehealth in order to protect that population. This CMS link here has all of the telehealth codes. They actually expanded them yesterday, which lists all the services that can be furnished via telehealth and the correlating billing codes. So that's another great resource. Obviously, it's great that we're doing telehealth now and everyone's doing telehealth, but the revenue cycle people ask, well, how are we supposed to get paid for this? Because everyone who's worked in this space for a while knows that telehealth reimbursement has always been very, very, very difficult. According to CMS and Medicare, they're going to pay you the same way they would as if the services were provided in person, and that you should bill them now as the services that were, as if the services had been provided in person, and then use that designated place of service code of 02 for telehealth. So that sounds like it's going to be a seamless. Let's hope that it is, but that's the kind of direction right now from CMS on how to bill these Medicare telehealth services. Georgia Medicaid has a manual posted on their website as it relates to telehealth, as well as some billing guidelines around it. They're using a telehealth POS code and a modifier. And they've eased their restrictions very similar to those that have been done by Medicare. So if you're interested in it from a Medicaid perspective, check out that manual on their website. All right, so we're going to switch over to billing, which is quite a mess. Some of you that have been dealing with this for a while may have been billing on this as far back as February and living this nightmare. Some facilities have been holding their bills because they don't know what to do with them. We just now in the last week got, I think, the full clear guidance on the billing. And in the April 1st release, which is today, a lot of these things should be available and released. So we did not have the emergency IC9 code until today, or excuse me, IC910 code until today. It went into effect today. There now is the official code for the 2019 novel coronavirus. You can still use these codes, the B97.29 code. They said they will still accept it. but it's a modifier or a secondary code to whatever the primary diagnosis is. But this is very important from a coding perspective. The B34.2 coronavirus unspecified, which is what apparently a lot of providers were trying to use to build this prior to us having the assignment of the code today, is an inappropriate code because this coronavirus is a respiratory illness, so therefore it is not an unspecified site. So if you have been using that B34.2, you need to stop. That one is not correct and will likely be rejected. There is not a specific COVID-19 DRG code, but Medicare did issue some guidance just last week regarding the different MCC classes and the DRGs that they would accept as it relates to the IC910 code. So that's some good information to get out to your coders. But as of today, you should probably use the new IC910 code in order to make sure that we're tracking these correctly. For the testing codes, CMS developed a second code for labs to build that are the non-CDC labs. So we had the code for the CDC lab test because, as you know, for a while, the only testing code or the only testing that was available was directly through the CDC. So that was the U0001 code. They developed a second code, which is U0002 for labs to build that are not using the CDC test. And you also may still use the CPT code if you're testing in office and you meet the criteria. There was an FDA policy issued on February 29th that kind of went through all these different tests. So whatever test you're using pursuant to that FDA policy is which billing code that you choose. These go into effect today, but they're going to be backdated to February 4th. So if you did run any tests in February and March, you can go back and recode them or correct them to meet these current standards. They also received, released and published what the particular MACs were going to pay for this. Palmetto, which is the Alabama, Tennessee, Georgia MAC, is paying $35.91 for the CMS or the CDC test and $51.31 for the non-CMS test. And that's basically average throughout all the MACs. There's another, on the CMS website, there's a document that you can pull that will show you the pricing for your individual areas if you're not in Alabama, Tennessee, or Georgia. All right, so CPT codes, the AMA got their CPT code updated and released, 87635. This became effective on March 13th. They have said that they are not going to get this into the electronic release until later this year. So that CPT code will have to be manually loaded into your system. This resource at the bottom from the from AMA is a phenomenal PDF that goes over how you bill and how you code for all the different situations with which COVID can come into contact. I highly recommend that you pull that and you look at that if you bill CPT codes. It's a really great resource to kind of go through how you would handle the billing. All right, so Medicare released a modifier for the public health emergency to attach to all of your formal waiver claims. So these are the things that we talked about at the beginning of the presentation, all the things that were included in the waivers. So then I get a question from my clients about, well, how do I know when to use this disaster-related or catastrophic-related modifier or condition code, you know, as it relates to those waivers, because those aren't really billing waivers. And the answer is that we're not entirely sure. I mean, there's some things that are maybe more obvious. If you know you're submitting a late appeal and you're doing it because of COVID, then that might be a situation. The 3-day stay, the lack of a 3-day stay is definitely something that you would obviously attach it to. I know there's probably some Medicare billers on the line right now that are cringing at me, as they usually are, because I'm, you know, the lawyer that tells them, well, this is what the government said to do, and they're raising their hand, usually if we were in person, saying, but that's not possible, Elizabeth, the system's not going to take it. So I don't know the answer to those questions right now. I don't think anybody does, but they did at least create these modifiers, so we know they exist for the future. And hopefully when it comes down to being able and needing to use them, the system will have been updated in a way with which it will accept them and not kick the claims back out. This PDF at the bottom is a document that CMS released specifically to this that may have a little bit more information that you'd be able to use. Okay, essential health benefits. So essential health benefits was something that was created by the Obamacare Act. And basically, essential health benefits are the things with which health insurance providers are required to cover without patients having copay responsibilities. So there was a lot of questions early on about COVID. Is COVID an essential health benefit? Because as you know, a regular trip to the urgent care or the ER for a flu or bronchitis or respiratory would be subject to those copay and deductible regulations and would not be considered an essential health benefit. So CMS did come out and say that officially the diagnosis and treatment of COVID-19 is an essential health benefit. So all medically necessary hospitalization, as well as any isolation and quarantine under the supervision of a medical provider during a hospital stay are covered EHB. Now, quarantine outside the home is not covered EHB. Telehealth may be covered or may not be covered depending on the scope of the treatment. So there's a lot of question around, you know, if a patient via telehealth contacts a doctor and a doctor says, I think you might have COVID-19, so don't come in and don't go anywhere, and I'm going to monitor you via telehealth, you know, I'm going to monitor you for a 14-day period via telehealth. That's a gray area right now because the quarantine isn't necessarily considered an essential health benefit. And the thing to remember around the essential health benefits and the discussion around essential health benefits, this is really just a discussion about cost sharing. So if something is an essential health benefit, then there's no cost sharing responsibility on behalf of the patient, but it has nothing to do with whether the service is covered or not. So just because something is not an essential health benefit doesn't mean that it's an excluded or non-covered service. So it may still be something that can be billed. It just may be something with which the patient has responsibility for, which gets us into the conversation that we're going to have about, you know, patient responsibility in general. All right, so looking at the pre-service department, pre-service is an interesting department this day. Outside of the emergency department, I read this morning on HFMA.com that 70 to 75% of elective procedures have been canceled, which is mind-blowing for a variety of reasons. So not a lot of action, I'm thinking, in your pre-service departments around that kind of thing, but there's a lot of action, of course, in the emergency departments and people that are seeking treatment. There's been a lot of conversation about what part of what we do as a revenue cycle in that emergency department is mandatory and necessary. If we're just looking at providing care to these people and keeping the population, including our employees, as safe as possible, what do we do about our registrars and our financial counselors that are sitting in the emergency rooms basically on the front line? I don't think anybody has the correct answer to that right now, and I surely don't. But from a perspective of, you know, things that you should think about, obviously long-term implications to your cash flow. You know, if you have a very bustling pre-service collection department in your emergency room and you cut it off, you know, what does that look like? How long are you cutting it off for? Without your financial counselors, how are you going to collect the information that you need from patients to build these accounts? What is your ability as a system to move to a technology solution? And then are these restrictions, you know, purely for your emergency department because that's kind of ground zero, or are you going to just put them in place across all facilities? There's a lot of conversation, you know, even in grocery stores and things like that right now about the passage of cash and inserting of credit cards and things like that, and those being mechanisms. So it's just a discussion that has to be had. I don't think there's a one-size-fits-all for any facilities. And then there's a lot of facilities that had gone to the biometric identification and self-service kiosks to bolster their pre-service kind of collection of data and information. And that, of course, is now stuff that's being touched repeatedly by multiple patients. And so if you do have to close those down, how do you retreat to how you were collecting money before? So those are the kind of discussion topics around the pre-service area of the revenue cycle. But I would say one thing, though, is that the collecting of demographic information. So
if we stop the financial counselors and we're not as concerned about collecting financial information, there still is that person that's going to have to be sitting there collecting the basic demographic information for the patient in order to, create the medical record that we need. And I would just make sure that you encourage them to make sure they're collecting all the information. Now is not a great time to not be collecting email addresses or not be collecting phone numbers, because some of those things, emails, text messaging, things like that, are some of the things we may have to move to in order to contact these patients, since we're not able to have a face-to-face conversation with them. So if you are going to pull back on your financial counselors, I would encourage you to encourage whoever it is that's collecting the demographic information to make sure they're getting all of the information. So then going into that post-service environment, there's a lot of impact to our kind of post-service collection environment. A lot of states are beginning to suspend debt collection activities through regulations, just advising people that they can't collect debt anymore, which is a very large deal for hospitals. There are some hospitals that are suspending their debt collection activities just for self-service reasons to their community. They don't feel like now is a good time to be calling people and asking for money. The Common Spirit, which is one of the largest hospital systems in the country, made a lot of splash in the news last week or the week before because they suspended all of their billing related to COVID-19. They basically came out and said they're not going to bill any patients, they're not going to bill insurance companies, they're just holding the bills. I think that's obviously, again, there isn't a right answer. It just really depends on where you want your bottleneck to occur. So do you want your bottleneck to occur in a in your kind of hold bit place where you're holding all these claims? Do you want your bottleneck to occur on the backside when you get denials because they weren't processed correctly? That was just kind of a move that they made, and I think it was mostly around making sure patients didn't get any sort of statements or anything like that. As we've seen, commercial payers have begun to waive co-pays and deductibles. They're also easing their network referral and prior auth requirements. I've always been a big believer in making sure you have somebody checking your commercial payer portals almost daily, because the payers have consistently changed the rules through those portals forever. And you've agreed in most of your health insurance contracts that you are subject to whatever's posted in those portals. Now it's more important than ever that you have somebody checking those commercial payer portals to see what they're doing specifically as it relates to, referrals, networks, prior auth, things like that. There's been a lot of questions about, are the changes that they're making, are they only related to COVID patients? Are they related to other patients, other actions within the system? So that's the best place to get that information. This link at the bottom of this side, the American Health Insurance Group has created kind of a place where they're tracking all of the large insurance providers' responses. So that's a great place to go and look just to get a general idea from the large payers what they're looking at. I know Georgia HFMA has been trying to keep up with the state payers and post that information as necessary. Workers' comp, this is a really interesting subject right now for me in particular. I was last week at home turned on the news in the morning and saw an ad from our friend in Atlanta, Ken Nugent, already looking for patients that have been exposed to COVID because of their job, which I hadn't even thought of, but it is going to create a very large, obviously there's a group of patients, healthcare workers in general, that's a no-brainer. But there's probably a group of patients or potential patients when you're thinking about grocery store clerks or shipping clerks, or people that are kind of on the front lines of this and having to continue to work. If they're exposed to COVID-19 and get sick of it, does it become a compensable workers' comp claim? And then there's also, Mr. Nugent seemed to be looking for people that were exposed because their employer made them come to work and didn't let them work from home. So just as we kind of go through this and work on, treating these patients and getting them paid, especially in the self-pay population, there may be a significant number of these patients that end up having workers' comp related benefits as it relates to these treatments, and that's something that we just need to be keeping on the radar. COBRA is something that I think has come up very large in the last couple weeks. There's news stories every day about employees being furloughed or laid off. Laid off is obviously easier than furloughed. Furloughed creates a little bit of a gray area as it relates to COBRA. But again, I think we find ourselves in a situation where if you even look back to 2008, we took a lot of action as revenue cycles to identify these patients that may be eligible for COBRA and don't know it or can't afford the premium. So depending on the cost of the stay, that's something that should also kind of be on the forefront of your mind. Is this a potential patient that may have COBRA benefits that we can cover the premiums for their COBRA benefits and get this large hospital bill covered? There's been a lot of discussion, as you know, or you may remember, in 2008 with the last kind of economic crash. The stimulus bills that came out of that included COBRA extensions. The COBRA extension has not shown up in any of the stimulus bills so far, but some people believe that that's likely coming down the road because of the number of people that have lost their jobs. Okay, so charity care. I'm getting a lot of questions about charity care right now as it relates to this. You know, there are hospitals that are considering offering a specific charity care exemption for COVID-19 cases, or specifically stating that all COVID-19 charges will be written off to charity. And there's absolutely nothing wrong with that. You do still have to document and publicize it in compliance with 501R. There's been no waivers as to 501R and the charity policies issued. So any sort of change that you make to your charity cases still does have to be approved and documented and publicized as it relates to 501R. So as 501R does allow you to choose whatever sort of criteria you want for the charity, but you just have to document it and publicize it. I would also encourage you to make sure you track your charity care related to COVID-19 with a specific write-off code. And the reason for that is some of the stimulus dollars and things that are being promised to hospitals are going to probably rely around this, and you don't want to have to be going back 6 months from now trying to figure out which ones that you wrote off for COVID-19 and which ones you just wrote off in general. So I would go ahead and create a specific write-off code and make sure that you track that. And then there's the other set of patients. We have our patients that have a COVID-19 diagnosis and treatment. And then we have another significant set of patients right now that are just finding themselves in a financial situation based on everything that's happened with this. They've been laid off, they've been furloughed, their business is doing bad. All of a sudden they may, be eligible for charity. There is likely to be a large rise in your charity applications. There needs to be some consideration on whether the criteria are going to remain the same or if they're different. And again, you may want to consider a specific write-off code for the kind of COVID-19 emergency financial situation, because that may be something that you can use later and track to get some of these stimulus dollars, so you can go back and say, we wrote off this, $5 million of AR because these patients were in a bad financial situation from a COVID situation, even though they didn't have a diagnosis of COVID-19. So, and again, any changes that you make for that, you can make changes that are only effective for a certain amount of time. So you could ease or change your charity application criteria for a small period of time. That just has to be documented and publicized and meet all the regulations of 501R. All right, a little bit about HIPAA, because HIPAA has come up a few times in this. On March 15th, the Secretary of HHS granted some waivers around HIPAA. Again, as I was talking about earlier, this is mostly related to the provision of care. So this first one, they want to be able to speak to family members and friends involved in the patient's care if the patient's on a ventilator. They don't want to have to deal with the opting out in the facility directory right now. They're telling you don't have to distribute a notice of privacy practices just to kind of help the burden. And then the patient only has limited rights to request privacy restrictions in a public health emergency. And then again, the confidential communications have been limited. This is mostly in response to an OCR bulletin that was put out in February, which basically reminded the population that, in a state of emergency like this, as it relates to something pandemic in nature, the public health officials are permitted to take actions that prevent or lessen the risk to the public without the consent of the patient. So they are permitted to disclose the patient's name in situations they wouldn't be before, particularly as it relates to first responders and also to caregivers. They need to be able to tell the nursing home that a patient goes back to that they've been exposed. They need to be able to tell friends and family while someone is laying on a ventilator, so they can figure out who all has come in contact with them. So again, as I stated at the beginning, these waivers are all related to public health and safety. They're not intended to relate to the provision of receiving payment. And I think that's an important distinguishment, because as it relates to the revenue cycle, if you relax your HIPAA requirements on the revenue cycle for the provision of payment, even, it does fall officially within one of those waivers, I think you could have a problem down the road, explaining why that was necessary, because one thing they have said since the beginning is that they are looking for good faith effort, and they're still looking for minimum necessary. So when you talk about good faith effort and minimum necessary, make sure you're not making any changes related to HIPAA that don't fit into those criteria and aren't mostly directed at the provision of care, and not necessarily directed at getting paid. All right, so while all this is going on and we're trying to collect all this money and cover all these shifts and get everything done, we have a significant number of potential staff members that are going to get sick or have someone who gets sick or potentially request FMLA. So the Families First COVID-19 Response Act, which actually is effective tomorrow. I've seen some press that says it's effective today, but it was 15 days from the date of signature, which is tomorrow, and it runs through the end of the year. It applies to public and private employees with 50 or less employees, and it may include exemptions for employers under 50 employees. So basically, the way the law is written, it gives HHS the authority to create exemptions, but those haven't been created yet. And as I stated, the law goes into effect tomorrow, so we're not sure if the exemptions will ever come out or when they will come out. So we have to assume right now, as of today, that there is no exemption unless they get something out today before the end of the day. Basically, this covers employees if they are quarantined by order of the federal, state, or local government. They're self-quarantined based on a medical provider's advice. They're caring for somebody who's quarantined. They have the symptoms. They're caring for a child whose school is closed, or they're experiencing any similar condition. So this definition is basically written so broad that it would be hard to find somebody who did not qualify for it. And so once they're qualified, they have a right to request up to 80 hours for full-time employment of emergency sick leave, and this regardless of the length of employment. So you could have an employee that could start with you today, and then tomorrow they could request their 80 hours of paid sick time. So this is paid time. And part-time employees are eligible for the average number of hours they've worked in the last 2-week period. And the pay rate does depend on the reason for their leave, and it includes caps. There's a chart that explains there's varying pay based on whether you are the sick person or you're caring for the sick person. And there are some caps in it, and then employers will be reimbursed with a tax credit. But basically, if you have an employee who states that they fall into any of those categories on that last slide, they are now eligible as of tomorrow to request 2 weeks off and get paid for it, and you do have to pay them. They also extended the FMLA in that same act. So the FMLA applies to employees who have worked for at least 30 days, whereas under regular FMLA laws, you usually have to have worked for a year. And basically those COVID reasons on that slide 2 slides ago become the new FMLA qualifying reason. So usually none of those things would be an FMLA qualifying reason, but now there's an FMLA qualifying reason, particularly that your children are out of school is a huge one, whether you have the virus or not. So you have to allow them 12 weeks of FMLA, at which they're paid 2/3 of their current wage after 10 days. So they go 10 days without pay, and then they get paid 2/3 of their current wage for the 12 weeks. This is capped at $200 a day or $10,000 a person. So this is a huge shift in FMLA policy, as you know. Usually an employee, again, they're not usually eligible until they've been there for a year, and usually FMLA is unpaid leave. If they don't have sick time or things to cover, FMLA requires you to preserve the position, but it doesn't require you to pay them. So this is requiring you to pay them at 2/3 of their current rate. And after that 10 days, during that 10 days, they can use that 80 hours of sick leave that I discussed before, or they can use sick leave they have accrued. So basically, they're looking at 12 weeks of paid leave. And this is a major concern to a lot of people because everyone's kids are home right now. And, you know, everyone has somebody that they know has been affected by the virus. And if our entire workforce starts to ask for 12 weeks of FMLA, that's going to be a very, very large concern. And again, employers are reimbursed the tax credit, so you'll get that money back on your taxes quarterly, but there isn't sort of stimulus money or anything like that to cover it now. But I just didn't want anyone on this call to be all of a sudden when your employees come to you tomorrow and say, hey, I'm invoking my FMLA, to say, sorry, that's not an FMLA reason, because it is in fact an FML reason as of tomorrow. All right, so the CARE Act, the Coronavirus Aid, Relief, and Economic Security Act, which is the stimulus bill that was passed late last week, it includes $100 billion for hospitals for COVID-19 related expenses and lost revenue. And I've read about this basically ad nauseum since that was signed, and nobody knows what that means. There are no definitions, there's no guidance, there's no direction as to related expenses and lost revenue. It goes into a little bit more detail and criteria, but it's a very extremely confusing right now about how that money is going to be allocated. That's why I stated it would be good to start tracking some of your charity write-offs and things like that, because that's one of the criteria that's been thrown around as a possibility. The way that this usually works in a normal time is the law is passed, and then the different secretaries of the departments that are effective, they pass or they put out proposed regulations. And then there's usually a comment period, and then there's finalized regulations. That process can take anywhere for 18 months to, we saw almost 5 years on some of the Obamacare regulations. So they're supposed to be fast tracking the regulations that are going to explain these things, but even at a fast tracked pace, not sure how long that's going to take. And then that in itself is a little bit nerve wracking, because once it's fast tracked, it may, without going through that comment period, it may not be of any help, because usually we flesh out a lot of things in the comment period of these laws. So that kind of all remains to be seen about what specifically that $100 billion is going to be used for as it relates particularly to hospitals, and the 250, the capacity expansion and response is a little bit clearer, but the kind of related expenses and lost revenue, there's just really no guidance right now regarding what that means. There is a little bit of guidance. One of the largest big things as it relates to the revenue cycle in this is the increase in the Medicare payment to the hospital by 20% for any patient treated and admitted with COVID-19. So that's extremely helpful, although I read something this morning that said even with that 20% increase, they're still expecting hospitals to lose $1,200 a patient as it relates to treating a COVID patient. A lot of questions have come in already. Okay, well, you signed this bill last Thursday and you increased the Medicare payment by 20%, but I already billed for patients in, February and March. Can I go back and rebill them and get that, 20% bump? And again, there's not a clear answer right now. My guidance at this point to my clients has been just go ahead and rebill it and see what happens. And not, because it could be, we may never get an answer to that question. It may have to be kind of a trial and error thing. We may have to rebill it, and then we may have to go back and appeal it. They delayed the scheduled cuts to disproportionate share payments until November, which is helpful. And then in the actual care relief, they stated that rural hospitals can request up to a 6-month advance payment or lump sum payment from Medicare. But by Saturday, CMS had extended that to all Medicare providers. So this past Saturday, CMS issued the Medicare Accelerated Payment Program and is allowing all potential Medicare providers. So basically, if you've submitted a Medicare claim within the last 180 days, you're not in bankruptcy, you're not under any kind of active investigation, or you don't already owe them money, you can apply. It's a very simple form. You can apply to receive this accelerated payment. And they're stating that they're going to start processing them with 7 days, which I'm sure is I've never known them to process anything in 7 days. That should be interesting. And cancer hospitals can request up to 100% of the past 6 months that they billed to Medicare. So whatever that amount was for the past 6 months, they can go ahead and request that amount now as an accelerated payment. Critical hospital access hospitals can request 125%, and then other providers are able to request 100% for the past 3 months. You just, as I said, you just fill out the form with your mask. You're supposed to receive payment within 7 days. And then what you do is you bill Medicare how you normally would. And the recoupment begins on day 120 for a period of the year. So the way that they're saying this works is they're going to give you a 6-month infusion of cash right now based on your last 6 months of Medicare billing. You keep billing Medicare as you always was. So you're basically getting double right now. But then at that 120-day period, as you're billing Medicare, they're going to start recouping their money. If the numbers hold steady, they should be able to recoup their money between the 120 and the year period. And if they can't, they're going to send you a bill at the end of the year to tell them what you know. So the whole point of this is to infuse hospitals with cash right now when there's issues preventing them from getting the cash that they need. I would say that this is, it's not a, free money thing, and it is money that has to be paid back. So you have to think through the implications of if you take that accelerated cash today, in 6 months, you're basically getting no money for billing Medicare for those 6 months. So since they're going to do the recoupment that way, 120 days from when you accept that cash payment, your Medicare billings are going to fall to zero. So you need to make sure that you're planning for that if you do and decide to take that accelerated cash program right now. All right, so as I said, it was meant to be a little bit of a whirlwind. I really wanted to make sure that we covered a significant amount of material in the hour because there is a lot going on, and I wanted to make sure that everyone kind of had a starting off place to take kind of their 5 key takeaways that they want to take back to their organization or things they want to research more in depth that speak to what they believe that they need in this time, and just create that kind of document where we have access to some of those different links and such. I included are really great resources that I encourage you to look at. Lori, do we want to try to answer some questions? I know we have very little time left.
Yeah, we do. We have 7 minutes, so let's see if we can get through it. And we have questions that have come in on chat and on the Q&A, so I'm just going to rotate between them. First question, can you distinguish which revisions are blanket waivers versus those that require an application?
So all of the 1135 waivers that are discussed on those first slides and available in that Medicare PDF, those are all blanket waivers. And even the state waivers will be blanket waivers as well. The only person that has the only application right now is the state applying with Medicare to apply those waivers to the state programs, not to, there's no need for providers to apply for waivers right now. They're blanket under the law.
Okay. Another question. I've heard that many providers are now more comfortable fulfilling patient requests for medical records electronically through encrypted email or through their MyChart site versus taking walk-in requests. So I don't know if you want to add to that or just go on.
I mean, I think that, there's really been no reason that we couldn't do that in the past. It's just been a comfort level. As an industry, we have not adapted to technology with emailing and texting as much as other industries or as quickly as other industries have. And a lot of it is just, based on fear. But, as long as you're following all of the encryption guidance that's in HIPAA, that hasn't, of course, been waived. I don't think that there is an issue with going ahead and doing that.
Okay. I was trying to, you were going really quickly, and I was trying to in the chat just include some of the links in real time, but I couldn't go as fast. Did you include in the presentation, do you have information regarding the new G codes for specimen collection?
I think that is included in the, I think it's included in that AMA presentation that I have a link to. that goes through all the different indicators in the office.
Okay. Next question. Do you know if CMS has changed the MBI Medicare billing requirement during the pandemic?
I have not read it. I have not read anything as it relates to the Medicare billing requirement. Now they've eased a lot of different things as it relates to documentation and things like that, but I don't recall reading anything specific to that.
Okay. Commercial plans have waived copays and deductibles. Does that apply to self-insured plans?
If the self-insured plans are being administered by the, if they're using the commercial plans as a TPA, then it would likely apply. But that's a very difficult question because it relates to the plan documents between the plan and the commercial payer TPA, and that's not something that we have access to as providers. It's kind of been an issue for a while. I would assume if they're using the TPA that they've waived it, but it's one of those things we probably won't know until we get to the backside of this.
Okay. And then please clarify the FMLA change. Is that for all employers or those under 500 employees?
Those under 500.
Okay. And then another clarification, if Critical Access Hospital can operate an acute care as an acute care hospital during the pandemic.
Correct.
Okay. Let's see. And then here's another one. Hypothetically, I submitted my request for hearing before COVID-19 hit, starting the clock for my position paper submittal. Now I'm reacting to COVID-19 and bed capacity logistics. I've not seen any relief cited for extending my submittal deadline with the OHCDMS portal. Have you heard anything from CMS or the PRRB on this?
So that would technically fall within that waiver as it relates to Medicare appeals. That's exactly the situation that waiver is supposed to address, that you have, you've submitted your appeal, you're waiting for your hearing, you're waiting to provide information, and now you're swamped with COVID-19. So the kind of easy answer is yes, you have extra time because that's what that says that you have. But the reality is that they haven't been clear as far as how that's going to play out. So if it was me, I would probably go ahead and send a letter just stating that you're requesting additional time under the waiver, just so it's documented that you did request the time.
Okay. Doesn't FFCRA exclude healthcare providers from the emergency paid sick leave and extended FMLA?
I don't. Yes, there is some exceptions under the new FMLA as it relates to providers of care. So it would relate to people providing care within the emergency room, but it wouldn't have any effect. I was doing this targeted towards revenue cycle employees, which would not fall within the exception, but actual caregivers, there are some exceptions to that.
Okay. The newly released HCPCS codes for COVID-19 specimen collection, she has G2023 and G2024. The person has read that this can only be billed by clinical diagnostic labs when the specimens are collected by trained lab personnel. Many of these specimens are collected by nursing staff. Will hospitals be able to charge and bill for these codes and be reimbursed?
I think that there hasn't been anything, I haven't read anything to that detail on coding, but based on some of the waivers that are being provided by CMS right now to allow different clinical professionals to provide different services than they would have been able to do before, I think that you could likely rely on one of those waivers in order to get that taken care of, but I'm not entirely sure that to that level of specificity, if any waivers have specifically applied.
Okay. The prior authorization requirements seem to vary depending upon the insurance payer. Do contracted payers have the right to decide whether they will require acute hospital emergency admissions and do retro auth reviews up to 90 days?
Technically, private practice payers have the right to kind of request anything that they want. at this point. That's why I'm really cautioning my clients to be really careful and look at specifically what is in the portal. There's, it looks great for Aetna or Blue Cross Blue Shield, or, I'm not picking on a particular provider, but to come out on the news and say we're waiving copays and deductibles, and we're not making our clients, do these priors off and all these things like that. And then they're going to go in that portal and they're going to, kind of upload the small print. I'm also concerned, just from reading some of them, that they're very vaguely written. So, I think that they likely will hold course as it relates to COVID patients. I'm concerned that they're not going to be as, nice about holding course as it relates to other services that are being provided in the hospital right now. So as it relates to the commercial payers, I would still be, encourage your UR teams to be, do as much as possible and be very careful as it relates to assuming that these broad waivers are going to increase. Because as I mentioned at the beginning of the presentation, unfortunately for the revenue cycle, our battle on the COVID-19 front is 6 months from now. When all these claims start denying, or we have all problems getting these claims through, or there's processing errors or things like that. So we're having to rely to take action based on these broad kind of recommendations and waivers that we're not actually going to see the impact of for many months down the road.
Okay. We still have quite a few comments and questions here, but we're past time, so I want to be mindful of that. Elizabeth, what I'm going to do is try to record all of these and get them to you for quick answers if we can, and include that as part of the materials that we upload on the Georgia HFMA website. Does that sound like a plan to you? Is that okay with you, Elizabeth?
That's totally fine. And then my email address is on this last slide. So if anybody has a particular question or wants to reach out to me directly, that's perfectly fine as well. And I'll try to get back to them as soon as possible.
Okay. All right. I know a lot of people are dropping off, but just a reminder that this is the first in our Wednesday webinar series that's going to be running through April and May. So every Wednesday in April and May at 1 o'clock, please join us here. And next week's webinar is what comes after the pandemic. Do your patient engagement strategies lead to a long-term relationship? We're sending out emails almost every day and on the weekly Georgia HFMA email. So please be on the lookout there for those to register. We have a ton of great content coming along with the great content presented by Elizabeth today. So thank you everyone for joining. Elizabeth, thank you so much for your presentation today. As you exit the webinar today, you're going to be routed to a survey, and one of those questions will ask for the email addresses of others who have viewed this presentation with you. Please be sure to provide that. This will be another way that we can share Elizabeth's presentation and also answers to these final questions. And it's also the way that you'll be receiving your continuing education credit. You can email me. My name again is Laurie Heavey. It's L-Heavey, L-H-E-A-V-E-Y @clearbalance.org if you don't receive that CPE form. And again, just a reminder that the presentation will be available on the Georgia HFMA website in a few days. Thanks everybody. Stay safe and have a great afternoon. Elizabeth, thanks again.